I'm Angela Jones from the Monash Partners team, and it's my great pleasure on behalf of Angela Todd, my colleague from Sydney Health Partners, to welcome you today to the third of our Consumer and Community Involvement in Clinical Trials webinars. We're really delighted that you're able to join us today. We've got a stellar range of speakers who are here to share their experiences of being involved in consumer advisory panels. And today, on the basis of feedback from you all, we want to kind of get to the nitty-gritty a little bit of what it takes to make these types of panels work, and our presenters are going to share some of their experiences. Just to refresh you, Sydney Health Partners and Monash Partners are both large-scale partnerships that bring together research, teaching and health service organisations with a vision around embedding research in healthcare, but also giving consumers, the community and health services a much stronger voice in research and ensuring it's aligned to their priorities. We're both accredited by our peak research body in Australia, the National Health and Medical Research Council. Before we continue, I wanted to acknowledge the traditional custodians of the land on which we're meeting today. In the spirit of reconciliation, I pay my respects to elders past, present and emerging. I also extend that respect to any Aboriginal and Torres Strait Island people joining us for this webinar today. We acknowledge and pay respects to our First Peoples wherever you are. Before I hand over to our first speaker, I just wanted to highlight to you some of the resources that have been developed by centres across Australia to strengthen consumer and community involvement. These are listed here, and we can certainly pop these into the chat. A Consumer and Community Involvement Handbook, which is a kind of a practical how-to developed by our colleagues in Western Australia. Telethon Kids Institute has recently launched an online program to build capacity of consumers with an introduction to consumer and community involvement. There's also a fairly comprehensive consumer involvement toolkit developed by the Australian Clinical Trials Alliance, and Monash Partners developed a series of online education modules to also build capacity. So all of those resources are widely and freely available via the internet. Just to let you know that we're recording today's presentation, and as we have done in the past, we'll make a copy of the recording available to you via link with a summary of the key points from our speakers today. It's now my great pleasure to hand over to Ken Young, our first presenter. Ken has extensive experience in leading community and social care provision in youth services and out-of-home care and disability services. He has a lived experience of a blood disorder, polycythemia vera, and Ken contributes very meaningfully to the Monash Partners Consumer and Community Involvement Platform, and it's been a great pleasure to work with him. He's also involved in a number of consumer activities in our partner organisations, including being a member of the Monash University Central Clinical School Consumer and Researcher Engagement Committee. Ken's also involved in a myeloproliferative neoplasms alliance group that he brought together, and has experience partnering with researchers and doing research. Ken is going to open our session today and provide some reflections on his experience of consumer and community involvement and what's important. Ken, welcome. Thank you so much for joining us, and over to you now.
Yeah, can't find the mute button. Hi, everyone. My name is Ken Young. I have been involved with consumer research and particularly around blood cancers for about the last 12 years. Initially with a group called Cytopia, which was a Melbourne early development research group. They developed a molecule which just earlier this year the FDA in America authorized, which was momelotinib. So it's a very long way from trekking out to Burnley to now this organization has been taken over by GlaxoSmithKline. So it's a long story, but it's a story which I think is worth telling in the first thing, because the researchers in the very early days came to me. They hadn't even met, they'd never met anyone with an MPN. In those days, it was still called a myeloproliferative disorder. The research was very new. People did not know about the, when I first was diagnosed, the genetic basis of MPDs were unknown, and basically there was an explosion of genetics and understanding of what happened to cause them MPNs. Now, I'm not a researcher in the sense of understanding the nitty-gritty of gene expressions and what leads to this and what leads to that. Consumers don't need to be. Consumers have expertise in other areas, and I think that that's the important work that the Central Clinical School Community and Researcher Engagement Group, of which I'm part, is teasing out. Very often, particularly researchers who've been around quite a few application rounds, are now saying, "Oh, I've got to find a researcher. Can you sign this document?" That's not the way to go. It's about long-term engagement. It's about building a process of trust, and particularly I've found it quite useful working with clinician researchers, particularly around some of the MPN work, which is a fairly rare disease, and most haematologists may only come across 1 or 2 patients in their clinical experience. So working with researchers and seeing our expertise as the lived experience. And so what is the lived experience? That's really important. Particularly one of the complications of polycythemia is splenectomy, or swollen spleen, and mine went to the point where it actually popped, and I had to have an emergency splenectomy. That focuses your mind on your disorder, and so people will say, "Oh, we can reduce the spleen a bit with this particular molecule or that particular treatment." That has real meaning for me, and that has real meaning for other consumers. One of the early stage treatments for MPN, polycythemia vera, is venisections or bleeding. It's a bit like, it feels a little bit like going back to the Middle Ages as a consumer, just sort of sitting there donating blood, and it's just being dispatched. There's now work that's being done around, and that's to reduce the iron load. And there are now research projects which are looking at hepcidin and other molecules to actually reduce the iron transfer, so that people can actually not have to go through the regular venisections. So there's ways in which the actual lived experience of consumers is really important part of the research cycle. And a project I'm currently involved with the Victorian Comprehensive Cancer Centre is a research project which is looking at precision medicine, but the questions are emerging from the consumers. It's a consumer-led research project looking at what is going to be useful for a number of consumers across a range of cancers. Another area of involvement is also recruiting other patients with our MPN disease. was also a co-author of a research paper with Dr. Elizabeth Pearson at Peter Mac, where we were looking at the impact of fatigue on patients with MPNs. And my role was, again, helping in recruiting, putting making the MPN community aware of the project, encouraging people to participate. So there's several different areas of where patients are important in the research project. I think I might leave it with that, but I'll give one particular insight, and that is that it really has to be a partnership. And that involves a joint understanding of some basic ground rules between the researcher and their consumers that they're working with. So thank you.
Thanks so much, Ken, and really, really valuable comments. And I think your emphasis on the lived experience of patients and consumers and how valuable that is in the research process is well made. Researchers don't understand that at all, and it's a very unique contribution to research. So thank you. It's my pleasure to introduce both a friend and colleague, Janelle Bowden, as our next speaker. Janelle is a scientist by training and has more than 20 years of experience working in clinical trials, both here in Australia and overseas. Janelle has a genuine commitment and passion for supporting consumers to be involved in clinical trials, both as participants, but more importantly, as partners. Janelle also leads a social enterprise called Access CR, which provides clinical trial and consumer engagement services to the research sector. She also is an incredible innovator in online blogs and other forums that connect consumers and researchers. So really, really delighted to introduce Janelle and looking forward to your presentation. Just before you start, Janelle, if I could mention, we'd really love to have your comments in the chat, and we'd also love any questions. If you could use the Q&A function, it just helps those of us on the back end filter between the different types of comments versus questions. Thanks very much, and over to you, Janelle.
Thanks, Ange, and I'm just going to try and get these couple of slides up to reassure everyone it's not going to be death by PowerPoint. We will keep it simple. So and there we go. All right. Just 1 second. There we go. All right. So as Ange has mentioned, I'm really grateful to Monash Partners and Sydney Health Partners today for this opportunity to come and have a chat with you about my experience with consumer advisory groups, both as someone that's helped support one and others, and as a consumer member of some advisory groups. So I'd like to begin by acknowledging that I'm coming to you today from the lands of the Wallumattagal clan in Sydney, and pay my respects to any Aboriginal and Torres Strait Islander people that are joining the call today. For those of you who don't know me, I think Anne's just kind of given my CV, so I won't go into that. But essentially over the last 5 years, I've been specifically concentrating on how to support trial participants and involve more consumers around the research and development life cycle in order to build bridges between the research sector and community. And my advocacy has led to the opportunity to be a member on consumer advisory groups and a consumer rep amongst other scientific peers. So over the last 12 months, I've also been collaborating with Health Consumers New South Wales and Sydney Health Partners on a project involving the establishment of Consumer Advisory Group. And their remit was to develop resources to increase participation in clinical trials. They're a group called Conviction, and there are a couple of members that I'll give a nod tip to today, a hat tip to, that are also on the call and be talking about their experiences today. So it's really my personal reflections on what I think are some key to success in establishing consumer advisory groups, sprinkled with a few of my own experiences being member of groups that I hope to share with you over the next little while. So what do I think are some of the keys for success? And the first one is really knowing your why. Why do you want a consumer advisory group or a consumer on your group? It can't just be because you want to get the next grant. There has to be a reason that's really going to motivate you to put in the required time, resources and advocacy that you'll need. You need to be invested. In a very busy, time poor, money poor environment, if you aren't connected with and committed to your why, it's very easy to disengage and find excuses and under-support consumers. I'm busy, I don't have time, I don't have money, I don't know what to do, no one will help. And this will all lead to failing to reap the benefits first imagined and a negative experience for the consumers involved. So with your why sorted, the next step is to plan and resource for the group. What is the purpose of the group? How will they input into the project, network or activity that they're there to do? Is it a short-term project or a long-term project that you might use for multiple projects? Are you just wanting to consult on your ideas, review your documentation, or will the group be generating their own outputs? Are you clear on what's expected of the consumers involved? Their time, their access to computers, paper, printers, data, internet, their expertise or experience of healthcare or being a consumer partner, their professional skills. What level of communication and skill and literacy will they need to be able to effectively engage? What diversity do you need to be able to have on your group, and what can you actually support in terms of location, age, tech skills, cultural or language backgrounds, gender? Is this all documented so everybody is clear on the expectations? What will constitute a conflict of interest and how will you manage this? What other legal requirements might there be? Contracts, confidentiality, for example. On a practical level, how often will they need to meet? Where? For how long? At what time? You can't assume that your working hours are going to be suitable for all the consumers on the group. Will meetings be virtual or in person? Can you support consumers that may not have easy access to computers, the internet, to data, that have accessibility requirements, who can't print documents, and who need help with transport to and from meetings? What resources will be required to prepare for, run and document meetings and outcomes? Will there be work in between that requires support? Will the consumers be compensated? And if so, how will payment be done? Who do you need to get approval from for the resources and expenditure required? What reporting is necessary? Essentially, what do you need and how will you fund and resource it? Because there's no point starting if you haven't really thought through these practical issues. So planning done, you can now set about recruiting the right people and sharing with them the expectations of the role. If it's a new group, you may also want to consider allowing that group to set their own terms of reference in how they'll work together. And once operational, you'll need to then support the consumers to fulfill their planned purpose. And key to that will be building successful relationships. So there's lots of questions in there, lots of things that you need to think about. And I thought it might be really useful as a case study to talk a little bit about the conviction group, how we set up and manage that, with a few reflections along the way on the groups that I've been a member of. So to begin with, there were 4 project partners and 6 individuals from those teams who were committed to the consumer voice in research. We all knew our own whys and are committed to making this project work, even if the money didn't cover everything. It was a 12-month project, a pilot project, and we believed if we were successful, that we could demonstrate the value of the group and the need to properly fund it into the future. We knew the group's purpose, to produce some educational materials, training and other resources that would perhaps drive participation in clinical trials in New South Wales, and we knew the timeline, 12 months. We then actually spent a couple of months thinking through the planning, who we needed, what skills and experience we wanted, how we would recruit members, how the project would be coordinated, administered, how we'd support the group to achieve their deliverables in a relatively short period of time. We wanted a group that was diverse in its ethnic backgrounds, its health experiences, its ages and locations across New South Wales, to ensure we had a broad church informing the project. So to recruit members, we developed a short video explaining the project, who we were looking for, which was about 15 people from diverse backgrounds with and without clinical trials experience, but with experience in networks as health consumer reps. And we provided an online expressions of interest form. This was distributed widely through the diverse health and consumer networks of the project partners, as well as social media. Importantly, we didn't just rely on tapping the people that we knew. So over 3 weeks, we received about 40-ish applications, and then we set about working to balance the committee with location, experience, and cultural background in mind. We invited about 18 people to participate in the group, and I think about 14 accepted. A couple of those had to pull out due to other commitments. We've had a pretty stable, steady dozen regularly attending our meetings about every month or so. In the first few meetings, the group agreed its own terms of reference, how they wanted to work together, and the name of the group, Conviction. They even came up with a logo, among other things. By the 5th meeting, 2 members of the team actually took over co-chairing the group. So it really was consumer-led, supported operationally by the project team. As mentioned earlier, you need to consider whether you'll compensate consumers, and that was something our team was very committed to. So a large portion of the budget was set aside for this purpose. And in retrospect, we still probably got it wrong as to underestimating how much time the Conviction members would give to this project. And so we need to continually check in with them to make sure that they're still okay about being involved and we're not demanding too much. Money isn't everything, of course, but there is an opportunity cost with time, and everyone needs to pay their bills. I know from my own experience that there's only so much volunteering that you can do. In the 2 groups I've been a member of, one group offered and gave payment, the process for which was relatively simple. The other group offered payment but never delivered. Though, you know, I still got some recognition for the work that I did because I've been included as an author on a paper that will hopefully be published soon, but that doesn't pay the bills. When those involving consumers follow through on their promises, you feel respected and valued as a consumer and are more likely to give extra. Not that that should be taken advantage of or expected. I spoke earlier of the need to think through how the group will be supported, who will take on what roles, for example. In the example of Conviction, each of the 6 project team members were assigned specific roles based on their skills, resourcing, and availability. We had someone responsible for admin and communication with the group, things like meeting agendas, minutes, logistics, overall project management, budgeting, contract management, and reporting. Someone else brought the subject matter expertise and facilitated group activities. Another brought infrastructure, payment, and consumer expertise. And all pitched in one way or another to help with supporting the advisory group subgroups deliver on their project outputs. What it meant was there was a clear line of responsibility for the project team, for the consumer group as to where to go for what, and always someone there to help them. The project team itself met between consumer group meetings to progress outcomes of meetings and plan, and a sub-team of the project group met with consumer co-chairs to prepare for the next meetings. We regularly communicated with the consumer members, and I know that doesn't always happen. The groups I'm members of typically only communicate when they're wanting something from me. They're not always there to just tell me they're not always communicating just what's happening or what's being done with the contributions of the group. So it can feel a bit on one-sided if it's only ever about what a researcher needs from the consumer group. With a short project or even longer term projects, to be productive, a group really has to gel quickly. You need to help people feel safe and supported with the ability to share personal information sometimes or to question or contribute ideas when they may be working with a group of people they don't know. Be mindful of power dynamics and decision-making processes. Give people the training or knowledge that they need to be able to effectively contribute to the purpose of the group. Be empathetic to the mental and emotional toll a project may have on somebody for the experiences they might be reliving. You may need to consider the need for access to mental health support. With the conviction group, we started meetings with 15 to 20 minutes of time just for sharing each other's activities and wins to build rapport. We then eased them progressively over a few meetings into the kind of work they would need to do, with activities that would give them the knowledge they needed to have to be able to work to the project deliverables. After a few meetings, we also held a training session to help bring everyone up to speed with their understanding of clinical trials at a time when they had had enough background and time to make that training useful. And I think it was about month 5 when the group actually started thinking about what they thought it was that they could deliver against the project aims. We remained open to their ideas on what they thought could make a difference. At the beginning, I talked about knowing the purpose of the group, and I think it's important to reflect from time to time on whether you remain on purpose or if it has evolved, and to think about how you measure the impact of the activity of the group and celebrate the achievements of the group. How we will share learnings from and demonstrate the impact of the conviction team is still a work in progress. We're presenting to different audiences like this, and that's a starting point. We can certainly document the outputs of the group in terms of the time invested and the resources they're creating. But I think there's also the professional and personal impacts that working with a group like this has that are much harder to quantify. The new friendships and networks formed, the greater understanding of a problem and views of it from different perspectives. In this case specifically, the building of capacity and knowledge about clinical trials in the consumer sector and the ripple effect that will occur from that. And while it is last on my list here, it might just be the most important. I think developing good relationships with and amongst the consumer group is a really critical factor. This will take time, but can be sped up if you're compassionate, considerate, open-minded, you share power, if you give as much as you take, and if you have some fun along the way. We've certainly got some characters on our group, one of whom is here today. So preparing for this meeting, one of the conviction group reflected that a group isn't really working if people leave or don't turn up to the meetings. And so I think we're doing something right with conviction as we've had a stable group. We've enjoyed great engagement throughout the project, and there's a real willingness and camaraderie to contribute and hopefully be refunded to do more. We've never taken the conviction members for granted, and I hope that they feel valued for their contributions. I know from my side, conviction meetings are one of the meetings I always look forward to attending. So in summary, there's been lots of reflections here, and I know that it's a key, I think the key areas that can really contribute to the success of consumer advisory groups: knowing your why, planning and resourcing for success, being supportive and building good relationships. It's not really rocket science after all. I mean, these are the things that make projects and teams work anyway. And it's not always easy, but in my view, it's time and money well spent to make sure that consumers are partners in research, contributing their views, inputs and experiences, and we're delivering outcomes that can really make a difference to patients and their families in the future. So feel free to connect and reach out if you need to. I have to apologise, I need to run to another meeting I'm presenting at 12:30, so I will need to leave about 10 minutes before the end, but I'm really looking forward to everyone else's insights today. Thank you.
Thanks, Janelle. That's fantastic. You almost made me cry. I think conviction, we've actually hit the lottery with conviction. You know, it feels like the big lotto win in New South Wales. We have an amazing group, and it's been a wonderful journey, and really enjoyed sharing it both within our project team, but especially with our unique consumer panel. Really terrific. And as you say, we've got a couple of people here on among our speakers. We've got time for a couple of quick questions, and just before we move on, I did see one earlier on for you, Janelle, but I think I've lost it. Wait a minute, it's in
WorkHag members also participants.
Thank you.
So So the CAG members actually drove the project. So they've developed everything, and we as a project team have literally just supported them to achieve what they wanted. So they've come up with the ideas that they want to develop, and briefly, it's some documents and some videos that they wanted to create. We've just helped them make it happen. They've created everything, they've written everything, they've reviewed everything. We've just helped make it happen. So it's been an absolutely delightful project to work on and something different. I hope that helps, Julia.
Thanks, Janelle. Angela, can I just check in with you whether I've missed anything else in the screen of comments?
And it's just a comment in the Q&A to bring to everyone's attention around to consider partnering with groups that have been built around conditions, specific conditions. Often people with the lived experience of that condition may be quite closely engaged, and they're often interested in working in research, and the operational leads in those organisations can often facilitate connection between research groups and people with the lived experience. So they can often create a pathway for researchers to engage with consumers and involve them. So just to highlight that, and thank you to the person who posted that comment.
No, that's a very good point. Janelle?
I'd endorse that point from Tara. It's because of our specific condition that I'm involved, and then it expands out into other areas, get kidnapped.
Yeah, and I think, and that really talks to the why that I'm talking about. You've really got to understand what you're looking for and who you're looking for it from to be successful. So in the case of our project, it was quite generic. It was just about clinical trials in general, how we can drive participation in trials. And so that needed a broad church of people with lots of different health conditions, lots of different backgrounds, lots of different locations, so that we're really informing that. But absolutely, if it's a disease specific, then you need to connect with that disease specific group. And there's a comment there around engaging consumers of low English proficiency. Yeah, this is absolutely an area of ongoing work. We do have some called representatives in our group, and you still kind of need one that communicate with their community. So they have been kind of a little bit of a go-to between our community, from our group to their group, and bringing them in. But yeah, it's absolutely a challenge. I don't have the answer to that one. It's something we have to be mindful of.
I guess I will also just throw in from my own personal perspectives. I think it's important to recognise that sometimes the formal committee structure is not necessarily the most culturally appropriate way to engage with some members of different communities. I think we think, that's our model of the way we work sometimes, but it's not necessarily the intuitive way that people collaborate and talk and share their experience and perspectives. So sometimes researchers have to also, if you can't bring Muhammad to the mountain, you bring the mountain to Muhammad.
There's also just a comment in the Q&A, and I think this is something for us all to be really mindful of, and that is just, if there are papers or documents from a meeting, that we circulate those in plenty of time, so that consumers have a lot of time to review the material, and there's time for discussions well ahead of the meeting to make sure that everybody's got a really good understanding of what's to be discussed, and also to have, to co-develop the agenda for meetings. So I think that's a terrific point also.
Okay, please don't hesitate to keep popping in some questions, but in the interest of time, we are going to move along. It's again my pleasure to introduce a colleague and really a rising star at the University of Sydney, I've got to say. I know, Stephanie, you won't mind me saying that. Stephanie Partridge is an early career researcher at the University of Sydney who's got a real interest in digital health and how texting and messages can really help as resources and tools to help people support better health outcomes. The reason that we've invited Stephanie today, though, and her colleague and PhD student, talk, Rebecca, sorry, is to talk a little bit about the unique work they're doing with young people, adolescents and young adults, and how they've been working with them and engaging them in their research. Really great work, and I can't wait to hear your presentation. So thanks, Stephanie and Rebecca.
Thanks so much, Angela. So thank you to Sydney Health Partners and Monash Partners for the opportunity to present the work that we've been doing here at the University of Sydney. So today, Rebecca and I would just briefly take you through really the lessons that we've learned in developing a youth consumer advisory panel. So next slide, Beck. I'd just also like to acknowledge the traditional owners of the land that we're presenting on today, which is the Gadigal people, and pay my respects to elders past, present and emerging. So just to give you a bit of an overview of what we're going to cover today, so I'll just briefly go over consumer engagement and adolescence. And I think we kind of touched on this with what Janelle was just talking about. We're really talking about a wide group of adolescents when we're talking about the prevention space, which is what we work in. So we're not looking at a particular young people with a particular health condition. We're looking at all kinds of young people who are interested in prevention and improving the health of their generation. I'll talk you through the Youth Advisory Group protocol that was set up and the evaluation framework that we've embedded within that program. And then Rebecca will take you through our Health for Need trial, which is an MRFF primary care funded grant that we got to develop a digital health program. And I guess it's with consumer engagement, we found it to be a bit of a chicken and the egg kind of situation, because obviously, as Janelle mentioned, we wanted to set up youth advisory groups, but we never really had the resources that we needed to be able to do that. So it was really exciting when we were successful for an MRFF grant, because it allowed us to be able to develop that youth advisory group, I guess, and have the resources available to be able to compensate our members and set up the structures that we needed. Next slide, please. So when I started to do this work, I looked for a framework that we could use to engage adolescents. And there has been a lot of different frameworks that have been developed. So this was a systematic review that was published in 2019. And they found 65 frameworks to engage consumers in health research. And most of them scored well when they looked at an evaluation tool, but they really found that there was no one-size-fits-all approach. And what I found most interesting, there was really no frameworks to engage adolescents in research. And adolescents are a really unique population group. And then when you look at the empirical research that's been conducted in adolescent populations, only fewer than 1% actually have a youth voice or an adolescent advisory group to support that research. Next slide. So this led my other PhD student, Marion Mendo, to conduct a systematic review. And we wanted to look at how young people are really involved in chronic disease prevention research. So we conducted a review over the last 25 years, and we found 71 studies that did have some level of adolescent consumer engagement, but most were just consumers who were consulted in the process. They weren't actively involved in decision-making related to that research. And we really found that there was no consistency in approaches to engage adolescent consumers. And I think what was most interesting, no one really looked at what was the effect of involving those consumers and what did they get out of that experience, which is something that we're really interested in. So there really was a lack of evidence to optimise and ensure effective, safe and meaningful engagement of adolescent consumers. Next slide. So that led us to develop, using that evidence and other existing evidence, a protocol for a youth advisory group to support our work. So this allows young people to work with us. So we're mostly public health researchers. And the goal is to identify and advocate for issues that matter to them relating to chronic disease prevention. And they're helping to and contribute to our research agenda. So we developed a 12-month program for young people who were 13 to 18 years. And it's guided by the Youth Participatory Action Research Principles. So that means it's inquiry-based, so topics of discussion are grounded in their lived experience. It's participatory, so they're collaborators in the research process. And hopefully we aspire that it's transformative, so they'll be able to actively intervene to change research to improve the lives of their communities from chronic disease. Next slide, please. So one of the things that we wanted to do with this program was to put an evaluation framework around it to really understand what are the benefits for young people who have joined this youth advisory group, and how can we ensure that they're getting the most out of it, instead of just focusing on the research that comes out of it. So we set up a 12-month evaluation where we collected baseline data, 6-month data and 12-month data. And we've just finished our 12-month data collection, which is really exciting. And so we're evaluating their self-efficacy, their leadership, their perceived research skills, as well as the collective participation. And we're also collecting logbooks and notes around how the barriers and facilitators to set up this group. Next slide, please. It's also embedded within a logic model, so I won't take you through this model, but we really try to work this group within our full research program to really drive forward and have this as a sort of a really underlying feature of our research and have it going every year. Next slide. So this is that we recruited this time last year. So I think, as Janelle said, we really didn't know what kind of people that we got, but we also feel like we hit the jackpot. So we got 16 members who were really engaged and wonderful. So we just put out a call on social media and through our own networks. We had a bit of an application form for young people, so they told us why they wanted to join and what they could bring in terms of their life experience. They didn't have to have any other work experience or anything like that. So we ensured that it was gender balanced. We ensured that there was young people from regional New South Wales, and we ensured that there was a bit of an age balance as well. Next slide. And in terms of how we operate, so this is something we really focus on in our first meeting. So how do they want to meet? So obviously online was the best, but they did want some in-person interaction as well, which we're able to facilitate this year. And we set up, they also discussed what platform would be best to communicate on, and that was Slack. So I think, unlike Janelle, because of working with young people, our members are usually quite busy with different elements. So there's often a mix of people who are coming to meetings versus people who are contributing online. So we really had to get used to that sort of different style of working, which was really, I guess, really different for us. And obviously after hours work as well to engage young people after school hours and on weekends as well. So now Rebecca, I think, is the next slide, will take you through how we've engaged with our, I've got one more. So this slide just gives you a little bit of preliminary data about our evaluation that we've done. So obviously we've got all the participatory outcome data that I mentioned before around leadership and research skills. But I think the most exciting and unexpected outcome that we had was the advocacy that came from this group. So these young people were so passionate about improving the health of their generation, and they were more than happy to sort of voice those opinions. They went on national television, they went and spoke at national conferences, and this is nothing that we planned throughout the group, but it was really exciting to see that advocacy was a really unexpected outcome. So now Rebecca will take you through the Health for Me study and how we've been using and working with our Happy Us group to engage with them.
Awesome. Thanks, Steph, for introducing the group, and hi to everyone online. My name is Rebecca and I'm a PhD candidate in the Engagement and Co-Design Research Hub at the University of Sydney. And I'll be talking to you today about how we engaged Happy Us in the Health for Me clinical trial, which forms part of my PhD work. So when I was thinking about this, I was kind of thinking about all the things involved in setting up a clinical trial. And as everyone online would know, there's a lot of work that goes into it. And I'm pleased to say that those items that are highlighted on the screen are all parts that this Happy Us group have contributed to the Health for Me clinical trial. So I thought I'd just quickly run you through Health for Me and what it entails. So Health for Me is a healthy lifestyle text message program for adolescents. It is a researcher-blinded virtual RCT. So virtual just meaning that there's no physical sites for recruitment and everything actually happens online. So the participants that take part in the trial will be adolescents aged between 12 to 18 years, inclusive, and have no underlying medical conditions. So an otherwise healthy population. The intervention itself is a 6-month two-way, meaning that the participants can reply, semi-personalised text message program with the option for health counselling as well. And the outcomes here, primary outcomes are the physical activity and nutrition outcomes with a suite of secondary outcomes, and I'll run you through why we chose some of them later on. The follow-up period is 6 months, and we're currently just refining the intervention before we start recruiting hopefully later this year or early next year. And what we hope to get out of this clinical trial is to provide high quality evidence and engagement, high quality evidence on the engagement and effectiveness of a positively framed text message program to improve nutrition and physical activity outcomes among adolescents. So, as I said before, Happy Us were involved in some of the parts of setting up this clinical trial. And the first one that I'll run you through is the intervention, because it's where they've had the most input. So we really wanted to make sure that this intervention was completely co-designed with young people. And so the first step was to identify the top issues to chronic disease prevention through online collaboration. Now, as Steph mentioned earlier, we did use existing tools such as Zoom, Slack, and Mural boards, which is like a collaborative whiteboard, to collaborate with these young people. And so they identified their 6 top issues for chronic disease prevention, which were unbalanced nutritional intake, physical inactivity, mental health concerns, the rise of social media, body image and climate change, and how these are all sort of interlinked and interconnected as well. And they actually wrote an essay detailing all of these 6 top issues and their interconnectedness. And this essay actually ended up being published in the Lancet Child and Adolescent Health. And so the next step was to develop the text message content based on these 6 key areas, but to improve their nutrition and physical activity behaviours. And we were lucky enough to bring them in person to do this. So we had a full day workshop with the Happy Us group. And from that, we were able to develop the text messages. So we did have an existing bank of text messages we had from a previous clinical trial, and we combined that with these new text messages that the Happy Us group created, which left us with a total of 219 text messages to review. Now, the next step is a little bit more comprehensive, and it is a published process where we invite a diverse sample of adolescents plus experts in the field to review these text messages. So each text message is reviewed by 3 experts and 3 young people, and they review them on a 5-point Likert scale from strongly agree to strongly disagree for ease of understanding and usefulness, and also for the appropriateness for certain age groups, which gives a total score out of 10. It's also got a space to suggest any sort of message improvements, or whether there's certain links that don't work or anything like that. They're able to provide feedback there. And so the next step is to sort of re-review that message bank to make sure it really has got the best evidence base we can have. And so any message that scores less than 7 out of 10 will be edited or deleted. Any adolescent comments are favoured over the expert comments, because sometimes these are a conflict. And then the final text messages are scored with a readability tool to ensure that they're all appropriate for a 7th grade reading level. And this forms the final text message bank that will be available and ready for testing in the Health for Me randomised control trial. So you can really see here how we've involved Happy Us, but also the wider community of young people to help develop this intervention. Next, I'll talk you through some of the aspects of the protocol development that they also helped with. So the next aspect is consent. And I think for anyone else online that works with young people, consent with young people can sometimes be a limiting factor in recruitment into clinical trials. And so we discussed this with Happy Us at some of our in-person meetings around the age of consent which they thought would be appropriate for an adolescent to consent themselves into a trial such as Health for Me, which is a low-risk community-based intervention. And so collectively, they decided that 14 years old should be the age that an adolescent can consent themselves into the trial, and they produced this statement. So with the evidence from the national statement and from the Happy Us statement, we included this into our protocol and submitted this to ethics. Luckily enough, we were approved this through ethics with no questions asked. So that means for any 14-year-olds or above who want to sign up into the Health for Me trial, they do not need parental consent, they can consent themselves. And so the next thing I'll talk to you about is just the outcomes. And so the involvement of Happiest really made us reconsider some of the outcomes for the clinical trial. Firstly, with the primary outcome, we are measuring physical activity using an activity tracker. And so we consulted these young people on the type of tracker that we think that we should use, whether it's a wrist-worn or hip-worn activity tracker. And what we found was that they said that they would all prefer a wrist-worn activity tracker. This will help us to increase compliance throughout the trial and hopefully get as much data as we can from these young people to make sure that our trial is effective. And for the secondary outcomes, we had previously sort of decided on these, but once we had looked at, those top 6 issues that these young people had identified, and really the interconnectedness of these 6 key issues, for chronic disease prevention, the importance of mental health really shone through. And so we decided to add some extra mental health outcomes as secondary outcomes to see whether there was any improvement of these throughout the trial. And so just in conclusion, I just hope that, this work shows how this youth advisory group and the wider youth community have been involved in the development of Health for Me, in terms of the intervention across the protocol development, and the list goes on. Hopefully they'll be involved throughout the span of the trial. And it's not without these challenges. We have to make sure that these relationships are equal, the engagement is evidence-based, and work within the research systems that we already have. But the benefits of engaging consumers in clinical trials can extend from developing the research question right through to the dissemination of results. Thank you.
Wow, what a fantastic presentation from you both. Thanks, Stephanie, and thanks, Rebecca. I think there's a million questions buzzing through my head, so I'm going to put some in the Q&A as well. But really, really fascinating work, and really showing, I guess, leveraging the voice of youth to really influence research design. And it's great to hear that what the young people are voting for trumps what the so-called experts say. So I love it. Love your work. That's great news. It's also my pleasure to now move very quickly to our next 2 presenters. It's my real pleasure to introduce 2 of the consumers on the conviction panel, Brian Dalton and Brad Rossiter. Brian joins us from Sydney, and who has a range of experience on consumer panels, both in private and public health sectors, with New South Wales Health and with tertiary institutions. One of his interesting hats currently is he is one of the lay people on an ethics committee. So I think Brian's going to talk a little bit about that, and also his experiences with conviction. And Brad is, I think, one of the characters on conviction. Brad hails from the South Coast in New South Wales, and in Batemans Bay, beautiful town. And Brad's got a fascinating history that you will hopefully have read on when you signed up for this event. But truly a superstar with a range of health challenges through his last 20 years. But despite those challenges, in fact, has been more active than I would ever dream to be. I don't know how he fits all of his activities into 1 week. So it's a real pleasure to introduce them. And my colleague, Joan Taroney, who really is one of the important backbones of the conviction group. She's going to join our 2 gentlemen just to help the conversation along if they get stuck. So over to the 3 of you.
Thank you, Angela.
Thank you. Thanks, Ange. We might hand over to you, Brian, to start then, if you'd like to.
Okay, Joan, thank you. So look, I'll just quickly share my screen so that we can commence. Okay.
Did you research how to use this, Brian?
I did. I did. And it's interestingly not coming up.
Yes,
so Brad, Is it coming up?
Yes.
Yeah, mate.
Yeah, great. So, as was introduced, I just want to talk about my experience as a consumer member or a layperson member of a research ethics committee. And this particular committee is the Sydney Health District, and it's a very extensive committee dealing with lots of research throughout the year. So as a layperson member or reviewer, I'm one of 3 on our committee, and then for diversity included in the committee are lawyers, pastoral care, clinical and professional care researchers. And then within that, we have a diversity across age group, gender, ethnicity, and obviously skills. So it's quite a robust committee. We have regularly 20 members, and within that there is a quorum, and all members are assigned particular studies in addition to reviewing all the studies each month. And that can be up to 30 studies per month. They can be clinical trials as well as quantitative studies. And there's also correspondence included in that, amendments and reports. So entering into consumer rep, being a consumer rep within a research ethics committee is, shouldn't underestimate what you are taking on as far as breadth and depth. Look, the key success factors are really having an active voice at the table. And for me, just sharing what those practicalities have been, it's certainly being well prepared for the meeting, for that monthly agenda. And linked into that is obviously, and I know this was talked about earlier, is ensuring that the materials are sent out to myself and the other members in a timely fashion. And we are blessed with a very, very efficient executive officers who work with us to ensure that the agenda and the contents are shared well in advance. And then they are there to field any questions. This does mean as a consumer rep that I must consistently devote the time for those prep and attendance, and that can be probably in excess of 4 hours a month. And also I need to have a familiarity with the relevant standards and guidelines. So the National Health and Medical Research Council guidelines, the clinical governance framework, and the clinical trials governance framework. And I say a familiarity because within the membership, there are also people which have ongoing expertise. That also means having a relevant lived experience. And in this case, it's being a study participant, having a background in research, both initiating research, but as mentioned, as a participant. Other consumer rep roles, and that's in addition to conviction, which was mentioned, but some others in the health space. An interest in ethics and what that means from a research perspective, and a capacity to understand the ethical issues and how they need to be interpreted into a practical situation, which research is. And a willingness to complete training as part of your membership, and as an ongoing quality improvement is to continue to be up to date with what goes on. And I'll overlay that with being effective has also meant I have a good health literacy. And that is an important part of having that voice at the table. It's all about speaking up and keeping true to your convictions. So it's about bringing an objective viewpoint, which may mean that it comes from a subjective space, but you're able to present it to the group in an objective way. A capacity to listen and appreciate the views of others and to formulate and express a considered opinion. Yes, challenge the status quo, most definitely, but that also means about leading solutions as part of a cross-functional committee. And over time, and it's been 6 years for me now that I've participated in this particular ethics committee, it's really about building a credibility over time as a go-to consumer representative within the committee. Always important, I've found, has been an ability to navigate the dynamics of a diverse membership, and that comes with respect and understanding of people's particular skills and where they're coming from in order to understand what particular viewpoints they might be bringing forward. Maintaining confidentiality, again, very important within the role. And whilst I mentioned the executive office, another key success factor in my experience has been having a very good chairperson who keeps the meeting timely, but is able to listen to everyone's opinion and synthesize and consolidate that to reach an appropriate conclusion on a particular research study. Some of the core consumer-centred good clinical practices that I now understand are best evidenced is through just this list of things which I think as a consumer representative I've found always to look for in a study, and that is the benefits outcomes of the study, the participant information sheet and consent forms. Is consent voluntary and informed? Is the information transparent and comprehensible? Where it's presented in English, if it's relevant, are there interpreters available in order to be able to recruit appropriately if there needs to be a particular ethnicity involved, or even where it may be that you're recruiting for people that have some form of intellectual disability. That the environments are safe, that the risks and burdens are acceptable and appropriately dealt with, both at a group level from the researcher's perspective, but also from the participant's perspective. That recruitment, it's equitable and not coercive. And by coercive, I mean where recruitment might be by a particular clinician, that there is enough time allowed between that recruitment, that an individual participant has time to consider that, to discuss that with family or with their local doctor prior to then actively agreeing to participate. That certainly when research is done with vulnerable cohorts, that those considerations are taken into account across multiple factors, not only from the research perspective, but also their access to participate in the trial and how they can be an ongoing member of that trial. That there is a data management plan, particularly relevant now with the recent cybersecurity and privacy issues. A strong data management plan across both the qualitative and quantitative study. That the principles of equipoise, where no harm, are maintained throughout the study. And I think the last piece which we are now looking at dealing with as an ethics committee in a particular health district is how are we seeing partnering with consumers evolving in the research studies, moving forward, but also retrospectively. I was very interested to hear in the youth research study how they have involved consumers, and that almost was a best practice case but that's what we as an ethics committee are now starting to look for, and that's given, and it's also another part of ethics that where consumers aren't involved, there will be implications for that in feedback to the researchers about how the study goes. So in a nutshell, it's being a consumer representative, layperson representative on an ethics committee is certainly a commitment. It's not a paid role. It is a pure voluntary role, but it has been very, very rewarding, both from a personal level, but also from the health outcomes that we are helping to facilitate. So thank you.
Thanks, Brian. I think there's some great practical advice and tips there for anybody who's considering venturing onto an ethics committee as a layperson or a consumer. And I think what you've just spoken to could be bottled and given as a training guide to new members across New South Wales, really. So that's fantastic. Much appreciated. Brad, so you're a very busy man in this space. We all know that. And like Angela said, I'm not sure how you make the time to fit it all in. So from your perspective, what motivates you every day to get up and do what you do?
Thanks, Joan. Thanks, Brian. Good, well done. Yeah, I live in the perfect place in Australia, Papers Bay, and have done for 37 years. I grew up in Sydney in the Southern Shire, and in 1970, just before I turned 6 years old, I was diagnosed with juvenile onset type 1 diabetes. And so I guess from that point in time, I became a consumer of health. My first little taste of what I can remember back, cast my mind back, was I was about 8 or 9 years old, and I was taken back to Royal Alexandra Hospital for Children at Camperdown, where myself and about 5 other diabetics about the same age, we all were for a couple of nights there, had blood tests taken, things. It is a fair while ago now too for me, but still, it was. I guess that's my first taste of research. And I don't know what really happened from there, because I think Mum and everyone was just, we had 5 kids at a good time at the hospital, I guess. So that's how it went there. But anyway, and so always looking at things from the way of nowadays. By my trade, I'm a butcher, which doesn't really have research, but it's okay. But still, I received a kidney and a pancreas transplant in 2007, and I was diagnosed with end-stage renal failure in year 2000, and also legally blind. And living down here on the south coast, there wasn't much happening here down this way regarding support or research or things about that I knew of that stage of renal disease or kidney disease. We had a nephrologist in Canberra, nothing stationed here, and so I went from being. My idea was to once I was on dialysis for 7 years, and I could see there was the other guys on dialysis that we all had a meeting when we had dialysis, and so it was we'd come together, had a yarn, a bit of talk, a bit of support. So I figured, well, that was the way to create what I created from after my transplants, which was the Uberella Renal Support Group and organ awareness. And not a lot to do with research, of course, but like the way I look at things is if you take the old adage of the cart before the horse, and the framework and things are put together, and you hear people talking, everyone's speaking today before me, the framework and everything that comes together is fantastic. It's amazing. It always amazes me to hear these things happen. The other committees I sit on too, all the people put the time and effort into to build these things to make sure that everything's right, the wording's correct, and the terms of reference are right, and all these things are happening, and they're getting it all going. But I guess if you have a fantastic horse and no cart, the horse just sits in the paddock. So my idea is to get the cart full of consumers to be driven by what's been made by the other people. If that makes any sense. If it doesn't, me either. That's like going with you. But still, it's putting together those things. So from over almost 15 years of receiving a transplant and having the opportunity to be back in the community again and talk to people about kidney health and organ donation, and I spent prior to COVID every single Friday from 2007 in our local shopping centre talking to people about our local community, because we're very close to Canberra, so we're very holiday orientated here on the coast, as you can imagine. And so we had a display or a table there every Friday right through the year with kidney health information and organ donor registration forms, plus other information that's happening in the Shire as well, and accessibility issues as well, because I am a double amputee, and so it became my idea that the more people get encouraged to become involved by understanding, the better it was. So that's why now I'm heavily involved with the conviction group, which, as I must say, when the conviction group first started, I thought this sounds really good, and the consumer representative on the conviction have been a real gel, as I said earlier too. It was a real moulding of people together that's just stuck, and it's fantastic. And it's a pleasure to dial up, oh, convictions on tomorrow, fantastic. And to hear people talk, listen to them, and pass ideas around to build what we're built into now. If this group, the nucleus of this group, ever breaks up, it'll be a real shame, because this is the #1 group. My go-to group would be this group for sure. and being involved with ACI and CCI across New South Wales and right through our local health district as well, where I chair our community consultation committee here as well. It's just amazing. So my idea for the research and to have people involved, you've got to get them their knowledge to them and tell them how good it is. And I think this is where the conviction is going to come forward as well, where from my perspective in here, involving my network and the people I speak to, plus then not only consumers, but the community. It's not going down, it's going up level or same level, because at some point in time, all community members may possibly be a consumer of health. And so if they got knowledge of what's happening and understand more about what's happening with whatever it be they need to have looked at or fixed or seen by a doctor or specialist or to help with research, I think that's a really good thing. I guess that most times you go to a doctor, you don't really hear much about research. You want to hear about him fixing you. But I think if we have knowledge of research, then once you are fixed, shall we say, in an easy term, then I guess that we become more favourably involved with the research on why that happened and for other people as well. And that's my motivation, is to do what I do, provide my life experiences, my skills and my knowledge and understanding of what I've been through, people I've spoken to and speak all the time, to put back into health department issues as well, to hopefully fix our rural and regional areas, to make it, well, not you can't fix it, sorry, bad word, to make our rural and regional the best it possibly can be through the understanding and knowledge of what we require. And that's sort of where I come from, and I'm wrapped. It's fantastic. So I think that all the guys here today have been amazing, and it's just great to hear that once again to the app and the wearing the thing out by the, I can't remember the lady's name, but that was amazing. Like, that's the way to go. Virtual care, all these things are fantastic. And yeah, so
that's
thanks.
great. So it's really about joining those dots, isn't it, and bringing everyone together. And I mean, you mentioned conviction, and I really think that there's a real equality to the group, and people listen to each other. Do you find that on the group?
Certainly, Jane. Yeah, it's one of those ones where everyone talks, and so they go, what listen intently. I do. Go, oh, hang on, what's that about? So, and you listen to it, so you really pick it up for sure, Jane. It's easy to talk to, and I know that, like, I suppose I'm a bit of a character. I don't know, but
you are, and
I like that. Health's pretty serious, but then again, it is what you make it, and if you can rock and roll and go with it, for sure. Happy day.
That's great. Well, I could chat to you all day, Brad and Brian, but I know we've got another speaker to come, and that's great to have your insight and your input, and we love you on Conviction, so we want to keep you guys forever. I'm going to hand back to Ange. Thanks.
Okay. Thanks, Brian.
Thanks, guys.
Thanks, Brad.
Thanks so much, Brad and Brian. What a great presentation. You're a terrific double act. I'm going to hand over to Angela Jones now.
Thanks, Ange, and thanks to our speakers. I find your presentations have been inspiring, and there's a richness to your story, which is just fabulous to hear. It's my great pleasure now to introduce to you Jo Ong. I have the great pleasure of working with Jo. She's the project manager supporting the Monash Partners Consumer and Community Involvement Platform. This is an area that Jo is particularly passionate about, and she's going to present today on some research that Monash Partners is doing in a project that we're leading. Thanks, Jo, and over to you.
Thanks, Angela. I'm just going to share my screen. So I'm the lucky last presenter today. My name's Jo Ong. I'm the Consumer and Community Involvement Project Manager here at Monash Partners. I'm going to share my preliminary findings from my scoping review and give you a snapshot of the Monash Partners Consumer Advisory Panel project. I'd like to thank the Monash Partners team, and particularly Angela and Sandy, for their support on this new project. So consumer and community involvement is one of Monash Partners' priorities and platforms. This slide shows the Monash Partners CCI journey to date. We've established advisory committees, appointed a CCI team including fellows, undertaken qualitative research to understand barriers and enablers, launched our CCI strategy, launched online education, training and practical resources. We've established an advice and support service, and Monash Partners has been involved in national programs and grants. Through these activities, Monash Partners is building CCI capacity and advancing CCI at the systems, organisation and individual level.
Whilst significant progress has been made to embed consumer and community involvement in research and health improvement, efforts in involving consumers in research often misses the mark, and it's still a bit of a dartboard. Efforts are sometimes ad hoc and uncoordinated with variable skill levels of how researchers work with the community. CCI done well, as we've heard today, whilst rewarding, can be short-term, resource intensive and costly, requiring training and often more time than what is available. Researchers are variably skilled and often don't have a good understanding of how to work with consumers. This can lead to frustration, consumer fatigue, and transient and sometimes tokenistic CCI roles. There are pockets that are done well, but the quality and consistency is highly variable, and it's not an optimal model to support consumers. So what can we do about this? How can we address many of these challenges? Monash Partners is well positioned to be brokers between researchers and the community. Monash Partners has started a project to develop an evidence-based model for consumer advisory panels, or CAPs. Consumer advisory panels are common in community organisations and health services. They are also named consumer advisory committees, consumer advisory boards or groups or councils. They have established infrastructure, training, governance, support and remuneration. There is a significant amount of time and resources in recruiting, establishing and maintaining these groups, as we've heard today. But a lot of consumer advisory panels are project specific and therefore time bound. So when the project ends, the panels come to an end. We see this as an opportunity to channel these resources to prevail over time. We would like to set up consumer advisory panels as a sustainable resource that is available to our Monash Partners network. Our vision is that the consumer advisory panels can support numerous projects and a range of other research and health service improvement activities, including providing advice and feedback on grants, which is really hard in our current system. But first of all, we need to understand the evidence. So we've commenced a scoping review to understand what are the key elements of a best practice consumer advisory panel. What are the processes and program mechanisms? What are the best strategies, principles, and governance arrangements? So basically the how, the not so exciting organisational bits, the nitty gritty of what works well in achieving and sustaining a consumer advisory panel. So this review is ongoing. So I'm just going to show just a small part of our findings. I'm sure for those of you who work in this area, these findings will not come as a surprise, and I hope that it reinforces the work that you're already doing. So the first theme from the literature looks at the principles of engagement with consumers and the community. And this was touched on briefly before. An important aspect of engaging is people working together where power balances that are evenly distributed and where everyone is of equal importance. Power balances can be achieved by taking the time to build relationships that can lead to open and honest dialogue and trust. Involving people from diverse backgrounds is important. This could be patients, carers, and the community from different ethnicities, geographical locations, and career stages, as well as researchers and clinicians. An important principle for researchers is valuing human experience and perspectives as relevant and important for research and health improvement. And I put this quote up here by Anderson, which I think captures the mindset that researchers need to have when involving consumers and the community. It's about respectful partnership with people. It's not about research working on, for, or about people. Another important principle is having a clear governance framework, including policies, processes, roles, and responsibilities. Good governance and infrastructure is necessary to support consumer and community involvement in consumer advisory panels. The literature suggests that partnerships are likely to work best when there is a clear vision and purpose, and all parties understand their individual roles and responsibilities. It's also helpful to have a code of conduct that outlines member behaviour, conflict of interest, and confidentiality. We're aware of the National Women's Health Translation and Network, which have a code of conduct for consumers working on committees. Please contact Monash Partners if you'd like a copy. Governance arrangements can also outline what remuneration is available. And I've just put up here Monash Partners remuneration and reimbursement guidelines, and we'll also put a link to this in the chat. The structure of advisory panels should ideally ensure diverse representation. Recruiting consumers from diverse backgrounds can be difficult, but can lead to identifying common priorities across community groups or within organisational contexts that are locally relevant and directly actionable. Excellent chairing, as we heard from Brian, is important as well. The panels where there is diverse representation between people who are not necessarily like-minded. Expert chairs can navigate disagreements or moments of discomfort while supporting consumers to feel comfortable in sharing their views alongside clinicians and researchers. And finally, good governance requires consumer support and follow-up, such as helping consumers to understand and digest information, supporting consumers between and after meetings, including providing feedback on their contributions, ensuring consumers can attend meetings by setting meetings at accessible times or online or at accessible locations. And I've just put up here Monash Partners Consumer and Community Involvement tip sheet around using Zoom. We also have tip sheets for using other online platforms such as Mentimeter, Mural and Google Meets. Another important theme from the preliminary findings is the need to build capacity through education, training, resources and support. Consumers need training and support to build their skills, confidence and experience. Providing educational opportunities and resources to organisational staff, clinicians and researchers can enhance professional practice that helps to bridge the traditional divide between community and academia. And activities that build capacity and skills of consumers, clinicians, researchers and organisational staff are vital to the success of any approach to consumer involvement. I've put up some images of some resources which Angela mentioned earlier, and I'm just going to briefly go through them since she's already covered them. So the Australian Clinical Trials Alliance have a consumer involvement and engagement toolkit that is useful for researchers wishing to conduct patient-centred clinical trials. The Western Australian Health Translation Network have a practical handbook that's suitable for a range of stakeholders interested in setting up CCI. West Australian Telethon Kids have an online program directed at consumers interested in involvement in health research. And Monash Partners has lunchtime seminar series. And we also have a series of 6 self-paced online modules for researchers and consumers. Another important thing from the literature, which I wanted to share with you today, is what is important for consumers. And I think we heard a lot of this today from our consumers who were talking. Being able to make a difference is important. This could be making a difference to diagnosis, treatment and service delivery, or contributing to something that makes a difference to others. Being heard and recognised as a voice of their community. This is an empowering and motivating experience for being involved in research or health improvement. Hearing other people's stories, participation can create a social network of supportive peers that can lead to relationships beyond the consumer advisory panels. Hearing other people's stories can be therapeutic and help to share their own experiences. And finally, being supported and valued is extremely important for consumers and for consumer engagement and involvement. My last slide looks at a couple of themes, but in the interest of time, I'll just briefly touch on them. The gaps in the literature include a lack of evidence on concrete outcomes. So more evaluation data is needed to measure short, midterm and long-term outcomes. There is a lack of standardization in definitions and methods relating to consumer and community involvement in research. And there's limited evidence examining consumer partnerships that focus on execution and evolutions over time. Another finding is the function or the scope of consumer advisory panels, and they are to enhance project processes and project outputs. They can increase project credibility and authority, and they also provide legitimacy through consumer and community involvement. So the next steps for our consumer advisory project are to complete the evidence review and the semi-structured interviews. We will develop a model that provides a pathway for research and healthcare improvement to connect with consumers. And next year, we hope to pilot 2 to 3 consumer advisory panels for a 12-month period. So what do we hope to achieve from this assistance approach to CCI that connects researchers in the community and hits the mark? Outreach to consumers in our community and the potential for consumers to be involved in their own community of practice. We want to build an alternate pathway for research and health improvement to integrate CCI into their practice. It's an opportunity for Monash partners to support and learn from consumers and capture our learnings of our experience by documenting and publishing our journey. And finally, we recognise that consumer research collaborations take time and perseverance. We hope that the consumer advisory panel projects can be part of a broader system to build CCI capacity. So thank you. I know that was a bit of a whirlwind in a really short amount of time. If you would like to learn more, I've put my contact details there, and I also have a copy of my references at the end of this presentation, which I'd be happy to share with you if you'd like them. Thank you very much.
Jo, thank you so much for sharing your insights from immersing yourself in the research and picking up the evidence. There's certainly lots of interest in the chat from people hearing the final outcome of the scoping review, and we'll be delighted to share that all with you when we complete it over the next few months. We've got just a minute or two left before we finish up. One thing I would say is that there are an enormous amount of incredibly valuable resources that have been generously shared through the chat today. What we'll do is we'll grab all of those and pop them into a document and a nice summary that will circulate along with a link to the recording. I think there's some really valuable tools there. Ange, are there any questions or comments that you've picked up in the chat?
Oh, do you know what? You just have to pinch yourself sometimes, Angela, with just the network of wonderful people that we manage to bring to these webinars. I think I hope our audience is as excited as I am. Is really, thank you so much to all of our presenters. What an amazing range of topics you've covered and experiences you've shared. It's just been fantastic.
I concur. I think thanks to everyone. If we haven't gotten to a question or comment today, please feel free to reach out to either the Monash Partners team or the Sydney Health Partners team. We'd be delighted to hear from you. We're also very keen to hear your feedback on today's presentation and ideas about future webinars that we can plan for the future. Today's webinar really came out of some of the very valuable feedback from previous presentations, and we hope you found our dive into the nitty-gritty of consumer advisory panels really useful in your practice around embedding consumer involvement in research and healthcare improvement. Just to iterate what Anne just said, a heartfelt thanks to all of our presenters today for taking the time to support our event, for your generosity and your insights. It's greatly appreciated. So on that basis, we'll sign off now and say thank you all so much, and we'll look forward to being in touch with further information about today's webinar and plans for the future. And thanks to everybody.
Thanks, everyone.
Thank you.
Great show.